I'm going to introduce next speaker, that is Dr. Moraru from Romania, that will speak about the role of intraoperative OCT in corneal transplant surgery.
Thank you, panelists, dear colleagues. I'm going to talk about what I thought is the role of the intraoperative optical coherence tomography in corneal transplant surgery. What we had, at least our experience in the last 3 years since we have this machine. I have no financial interest. We use in Oculus Eye Clinic in Bucharest the N-Focus Leica intraoperative live tomography. And I've chosen for this presentation some of the cases in which I think that this intraoperative live OCT really helped me in making some decisions. Except for the PKs presented in this presentation, all the other cases, lamellar procedures, were in the surgeon in my learning curve. And I took into consideration 17 corneal transplants, among which 9 were DSAEK and ultra-thin DSAEK, with the lamella prepared in the OR by the surgeon. 4 eyes were complex cases with PKs with prior PK, which were opaque and failed and necessitated a new PK. 3 eyes were with deep anterolamellar keratoplasty for keratoconus, and 1 eye was with DMEK for Fuchs dystrophy. Let's start with the role in the DSAEK cases. As you know, intraoperative OCT helps us in better observing the complete deciment detachment, the poor position graft, or if it is a space or not between the lamella and the stroma. Or you can also see the angle of the eye, and this is one of the cases. I repeat, all of them were in my learning curve. Today maybe I could see this without its help. And you saw the remnants of the detachment, which was not completed. The deciment was not completely detached. This is another case where the lamella went directly to the iris, and it helped me, the OCT helped me in visualizing where exactly to insert my air bubble and VSS, and also to follow the angle, to see, to notice if the angle is close or if it is in contact with the lamella, and help me in better centrated. This is another case where I implanted I injected the lamella and it was folded, and the OCT helped me, as you see with the red arrow, helped me in observing in which direction the folded was. So thus helped me in showing me the place where to inject the BSS and then the air bubble. Another case, you can see here, that was a nightmare for me. It went a bit of directly folded in the anterior chamber, but as you can see in the OCT image, it was folded towards the stroma. So it was quite a difficult case for me. At the end, it was okay, but quite difficult. And you see, it helped me to see exactly where to go with the air cannula. Another case, the implantation was absolutely okay. I wanted to centrate it better with gentle massage, but it seems I was not gently enough, because look what it happened. And I asked for the OCT, and again, it helped me, really helped me in visualizing the folded in which direction. And the final, at the end, I resolved it as in my first case, just on previously. Here there are 2 cases in which I checked the angle. The visualization due to the opaque stroma was not that good, and I noticed that the iris was not only, the angle was close, but the iris was in contact with the lamella, and helped me in taking and solving this situation. And this is my very first DMEK procedure with a preloaded DMEK. Look how it is. Not only with the, of course, with the rotellum, but it's upside down. So OCT really helped me in managing to put it in the right position. Let's go now to the dark eyes. Some of the first eyes, I was not sure about the air bubble, if it is there or not. And this is another case where, again, I was not sure if it is there or not, and it was not. This case was converted to PK. The former case was visible the air bubble, so I went on with a dark procedure. Another case where the second post-op day I noticed space between the deciment and the stroma, and the OCT helped me. Of course, the second day I had to go again in the OR to put some air and trying to attach the detachment, and the OCT helped me in observing how much exactly, how much air I needed to inject in the eye in order to have a complete attached DSAEK. But also it helped me in PK's cases, like these ones, for example. And you can see here, at the end of the surgery, you are not able to see the angle and the periphery of the iris, but the OCT, as you can see, helped me. Of course, you can do this with a spatula, but you don't want to manipulate too much the spatula in the anterior chamber. So if you have an OCT, the OCT shows you exactly where the iris or the angle is closed, and go directly, look here, you go directly with the spatula there, and you solve it quite quickly with less trauma in the eye. Similar cases for the PKs. You see, you cannot see anything in the periphery. Intraoperative OCT is known for its help in DMEK surgeries, but the benefits and help in decision-making steps of DSAEK, DAG, and PK procedures are less highlighted. Intraoperative OCT allows, as you can see, a better visualization, especially when advanced corneal opacities preclude good anterior chamber visualization. Thus, it brings more confidence for the surgeon doing the procedure, especially for several surgical steps, and it offers a higher safety profile for the surgery and for the patient, of course. Thank you.